Hypertension, or high blood pressure, is one of the most important preventable causes of cardiovascular disease, chronic kidney disease, cognitive decline, and premature death. It is common, usually silent, and often discovered only during routine measurement. In this video, we will build a complete clinical picture of hypertension. We will define blood pressure categories, distinguish primary from secondary hypertension, review risk factors and complications, explain how the diagnosis is confirmed, and work through the initial patient evaluation. We will then cover lifestyle treatment, antihypertensive drug classes, treatment in important patient groups, severe hypertension, and hypertensive emergencies. Blood pressure thresholds and treatment targets are not identical in every guideline. Whenever European and American systems use different terminology, I will make that difference explicit so that the numbers remain clinically meaningful rather than confusing. What does blood pressure mean? Systolic pressure is the highest pressure when the ventricles contract, while diastolic pressure is the lowest pressure when the heart relaxes. Blood pressure depends mainly on cardiac output and systemic vascular resistance. It can rise when the heart pumps more blood, when the arterioles constrict, or when blood volume increases. European and American guidelines use different categories. The European guideline defines hypertension as 140/90 or higher, while the American guideline begins stage 1 hypertension 130/80. Although the labels differ, cardiovascular risk increases continuously as blood pressure rises. Primary hypertension, also called essential hypertension, means persistently high blood pressure without one single identifiable secondary cause. It is the most common type of hypertension and is multifactorial. Some risk factors are non-modifiable, such as age, family history, genetics, and the broader social environment. Other risk factors are modifiable, including high salt intake, obesity, physical inactivity, poor diet, alcohol, smoking, sleep apnea, diabetes, dyslipidemia, and some medicines or drugs. Important underlying mechanisms include abnormal kidney sodium handling, RAS activation, increased sympathetic activity, endothelial dysfunction, and vascular stiffness. Primary hypertension usually develops gradually. If blood pressure starts very early, appears suddenly, becomes resistant to treatment, or is associated with hypokalemia or worsening kidney function, a secondary cause should be suspected. Hypertension is often a silent condition and may cause no symptoms at all. When symptoms do occur, they can include headache, chest discomfort, palpitations, blurred vision, or nosebleeds, but these are non-specific. A blood pressure above 180/120 millimeters of mercury is considered severe hypertension. However, the number alone does not define a hypertensive emergency. The key question is there acute organ damage? Hypertensive emergency means severe blood pressure elevation with acute target organ injury, such as brain, heart, aortic, kidney, or retinal damage. Warning features include confusion, neurological deficit, seizure, severe headache, chest pain, dyspnea, visual loss, or oliguria. These patients need urgent specialist management and controlled blood pressure reduction. If there is no acute organ damage, the blood pressure should be rechecked. The patient should be assessed promptly, and treatment is usually with oral medication. Rapid blood pressure lowering should be avoided. Persistent hypertension damages blood vessels by causing endothelial dysfunction, atherosclerosis, vascular remodeling, and arterial stiffness. This creates a cycle in which high blood pressure damages vessels, and damaged vessels further raise blood pressure. This vascular injury leads to target organ damage in several systems. In the heart, it can cause left ventricular hypertrophy, heart failure, myocardial infarction, and atrial fibrillation. In the brain, it increases the risk of stroke, bleeding, and cognitive decline. In the kidneys, it can lead to chronic kidney disease and albuminuria. In the retina, it may cause retinopathy and papilloedema. In the aorta and arteries, it contributes to peripheral arterial disease, aneurysm, and dissection. The key clinical message is that target organ damage means higher cardiovascular risk and usually calls for more intensive assessment and treatment. Accurate diagnosis begins with correct blood pressure measurement. Use a validated upper arm device with the correct cuff size. The patient should rest, sit with the back supported and feet flat, keep the arms supported at heart level, and avoid talking, caffeine, smoking, or exercise beforehand. At the first assessment, measure blood pressure in both arms. Repeat elevator readings and use the average rather than relying on one isolated measurement. Whenever possible, confirm hypertension outside the clinic using home monitoring or 24-hour ambulatory blood pressure monitoring. This helps detect white-coat hypertension, where clinic pressure is high but home pressure is normal, and masked hypertension, where clinic pressure is normal but out-of-office pressure is high. Using the thresholds shown here, clinic hypertension is at least 140/90, while the home or daytime ambulatory threshold is at least 135/85. After hypertension is confirmed, the initial evaluation has three main goals: estimate cardiovascular risk, identify target organ damage, and look for evidence of a secondary cause. Begin with a focused history, including family history, cardiovascular and kidney disease, diabetes, sleep apnea, diet, salt and alcohol intake, smoking, physical activity, pregnancy, and any medicines or substances that may raise blood pressure. The examination should include body mass index and waist circumference, pulse, signs of heart failure or vascular disease, peripheral pulses, bruits, and features suggesting thyroid disease, Cushing syndrome, or postural hypertension. Baseline tests usually include electrolytes, kidney function, glucose or HbA1c, lipids, urine albumin, an ECG, and retinal assessment. Further testing for secondary hypertension, such as aldosterone and renin, metanephrines, thyroid or cortisol tests, renal imaging, and sleep studies, should be guided by clinical clues rather than performed routinely in every patient. Finally, cardiovascular risk tools such as SCORE2 or PREVENT can help guide treatment decisions. Secondary hypertension means high blood pressure caused by an identifiable underlying condition or exposure. It can occur at any age, but it is especially important to consider in young patients and in resistant hypertension. A secondary cause should be suspected when hypertension has young onset, appears abruptly, is severe or resistant, is associated with hypokalemia, causes target organ damage, or is accompanied by episodic symptoms. A useful way to remember the causes is recent. R stands for renal causes, E for endocrine causes, C for coarctation of the aorta, E for estrogen-containing medicines, N for neuro causes and sleep apnea, T for treatments, toxins, and substances. In practice, some of the most important causes are kidney disease, primary aldosteronism, obstructive sleep apnea, medications or substances, and renovascular disease. Kidney disease can be both a cause and a consequence of hypertension. In renal parenchymal disease, reduced nephron function impairs sodium and fluid regulation, which can raise blood pressure. Examples include chronic kidney disease, glomerular disease, diabetic kidney disease, and polycystic kidney disease. In renovascular hypertension, narrowing of a renal artery reduces kidney perfusion. This activates the renin-angiotensin-aldosterone system, causing vasoconstriction and sodium and water retention. The main causes are atherosclerotic renal artery stenosis and fibromuscular dysplasia. Important clues include abrupt or resistant hypertension, an abdominal brood, unequal kidney size, recurrent flash pulmonary edema, worsening kidney function, or a marked creatinine rise after starting an ACE inhibitor or ARB. Evaluation may include duplex ultrasound, kinetic, or MR angiography, with catheter angiography mainly used when intervention is being considered. Most patients with atherosclerotic disease are treated medically. Kidney function and potassium should be monitored with ACE inhibitors or ARBs. Revascularization is reserved for selected high-risk cases, while renal fibromuscular dysplasia may be treated with balloon angioplasty. Primary aldosteronism is excessive aldosterone production that occurs independently of the renin-angiotensin system, so aldosterone is high and renin is suppressed. It may arise from one adrenal gland or from both. Aldosterone causes sodium and water retention while increasing potassium loss, leading to hypertension and sometimes hypokalemia or metabolic alkalosis. However, potassium may be normal, so a normal result does not exclude the condition. Screening is performed using the aldosterone to renin ratio, together with a potassium measurement. A positive result is followed by further evaluation, including adrenal CT and, when needed, adrenal vein sampling to determine whether the excess aldosterone comes from one or both adrenal glands. Unilateral disease may be treated with adrenalectomy. Bilateral disease or patients who are not suitable for surgery are treated with a mineralocorticoid receptor antagonist such as spironolactone or eplerenone. During treatment, monitor blood pressure, potassium, kidney function, and renin. Cushing syndrome is caused by chronic glucocorticoid excess. The most common cause is long-term prescribed steroid treatment. Endogenous disease may result from a pituitary or ectopic ACTH source, or from an adrenal tumor producing cortisol. Excess cortisol increases vascular sensitivity and fluid retention, which can contribute to hypertension. Typical features include central weight gain, a moon face, buffalo hump, white-purple striae, easy bruising, thin skin, muscle weakness, diabetes, and mood changes. Diagnosis begins with a careful drug history. Initial testing may use 24-hour urinary free cortisol, late-night salivary cortisol, or the overnight 1 mg dexamethasone suppression test. A random cortisol measurement should not be used as the initial test. Once cortisol excess is confirmed, aids to testing and imaging help identify the source. Treatment targets the underlying cause and may involve surgery, medication, or radiotherapy. Long-term steroid treatment must be tapered gradually and never stopped abruptly. Several endocrine disorders can cause secondary hypertension. Pheochromocytoma is a catecholamine-producing adrenal tumor, while a similar extra-adrenal tumor is called a paraganglioma. The classic presentation is episodic headache, sweating, and palpitations, often with severe or fluctuating hypertension. Diagnosis is made using plasma-free metanephrines or urinary fractionated metanephrines. Treatment is usually surgical, but preparation is essential. Alpha blockade and volume replacement must come first. A beta blocker may be added later for persistent tachycardia, but it should never be given before adequate alpha blockade. Thyroid disease can also affect blood pressure. Hyperthyroidism often raises systolic pressure and causes tachycardia, tremor, heat intolerance, and weight loss. Hypothyroidism may instead raise diastolic pressure through increased vascular resistance. Hyperparathyroidism and hypercalcemia can also contribute to hypertension. Pheochromocytoma, medullary thyroid carcinoma, and hyperparathyroidism may occur together in men too. Other important causes of secondary hypertension include coarctation of the aorta, obstructive sleep apnea, medicines, and substances. Coarctation of the aorta causes higher blood pressure in the arms than in the legs, with weak or delayed femoral pulses. Diagnosis is confirmed with cardiac and vascular imaging. Obstructive sleep apnea should be suspected in patients with loud snoring, witness apnoeas, daytime sleepiness, obesity, or resistant hypertension. Diagnosis is made with a sleep study, and treatment may include weight reduction and CPAP. Estrogen-containing contraceptives and several other medicines can raise blood pressure. Examples include glucocorticoids, NSAIDs, decongestants, stimulants, some antidepressants, calcineurin inhibitors, erythropoietin, and licorice. Cocaine and amphetamines may cause severe, dangerous hypertension. Raised intracranial pressure can produce hypertension, bradycardia, and abnormal breathing. This is an acute neurological emergency. When hypertension is caused by medicine or substance, the main principle is to remove or replace the trigger when it is safe to do so. Hypertension treatment has two main goals: lower blood pressure safely and reduce the risk of stroke, heart attack, heart failure, kidney disease, and death. Lifestyle treatment is recommended for everyone. This includes weight management, reducing salt, regular exercise, a healthy diet, limiting alcohol, stopping smoking, and improving sleep. The decision to begin medication depends on the average blood pressure, cardiovascular risk, organ damage, other medical conditions, age, frailty, and pregnancy. The American Guideline generally recommends treatment for blood pressure of 140 over 90 or higher, and from 130 over 80 in patients with increased cardiovascular risk. Stage 2 hypertension usually requires two medicines. European guidance also favors an initial low-dose two-drug combination for many patients, while one medicine may be suitable for selected low-risk, frail, or vulnerable patients. Treatment targets differ slightly between guidelines, but therapy should always be gradual and individualized, with monitoring of standing blood pressure, kidney function, electrolyte symptoms, and side effects. Lifestyle treatment is recommended for everyone with elevated blood pressure or hypertension. These measures can work together to lower blood pressure and reduce overall cardiovascular risk. Important steps include achieving a healthy weight, following a DASH-style diet, reducing sodium, and exercising regularly. Increasing potassium-rich foods may also help, but this requires caution in patients with kidney disease or those taking medicines that can raise potassium. Alcohol should be limited, and smoking or other nicotine exposure should be stopped. Good quality sleep is important, and obstructive sleep apnea should be assessed and treated when suspected. Stress management may also support well-being and treatment adherence. Lifestyle goals should be specific, achievable, and reviewed over time, rather than limited to general advice such as eating better or exercising more. The main first-line medicines for uncomplicated hypertension are thiazide or thiazide-like diuretics, ACE inhibitors, ARBs, and long-acting dihydropyridine calcium channel blockers. The choice depends on comorbidities, contraindications, and tolerability. Thiazide-type diuretics reduce sodium and water retention. Important adverse effects include low sodium or potassium and gout, so electrolytes and kidney function should be monitored. ACE inhibitors reduce angiotensin II and aldosterone. They may cause cough, hyperkalemia, increased creatinine, or rarely angioedema. ARBs have similar effects but are less likely to cause cough. Both require monitoring of potassium and kidney function and should not be used during pregnancy. Dihydropyridine calcium channel blockers, such as amlodipine, produce arterial vasodilation. Common adverse effects include ankle edema, headache, and flushing. Common combinations are an ACE inhibitor or ARB with either a calcium channel blocker or a thiazide-like diuretic. Single pill combinations can improve adherence. However, ACE inhibitors and ARBs should not be combined. When first-line treatment is not enough, several additional antihypertensive drugs may be used according to the patient's comorbidities and clinical indication. Beta blockers slow the heart and reduce renin release. They are especially useful in patients with ischemic heart disease, previous myocardial infarction, arrhythmias, heart failure, or certain pregnancy-related indications. Important adverse effects include bradycardia, fatigue, and possible bronchospasm. Loop diuretics, such as furosemide, are mainly used when hypertension is accompanied by heart failure or edema or advanced kidney disease. They can cause volume depletion and electrolyte disturbances. Mineral low corticoid receptor antagonists, especially spironolactone, are commonly used as the fourth drug in resistant hypertension. Potassium and kidney function must be monitored because of the risk of hyperkalemia. Other add-on options include alpha blockers, central agents, and direct vasodilators, but their adverse effects often limit routine use. Intravenous nitroprusside is reserved for selected, closely monitored hypertensive emergencies. Before diagnosing resistant hypertension, confirm the blood pressure, check technique and adherence, remove interfering substances, and look for secondary causes. If true resistance remains, spironolactone is often added when it is safe. Antihypertensive treatment should be chosen for the whole patient, not just the blood pressure number. In heart failure with reduced ejection fraction, treatment should follow heart failure therapy, including an ARNI or ACE inhibitor or ARB, a beta blocker, a mineralocorticoid receptor antagonist, and an SGLT2 inhibitor with loop diuretics for congestion. In diabetes or chronic kidney disease, an ACE inhibitor or ARB is especially useful when albuminuria is present with monitoring of potassium and creatinine. In asthma, avoid unnecessary non-selective beta blockers. If a beta blocker is truly needed, a beta-1 selective agent may be used cautiously. In older adults, treatment should be individualized, especially in frailty, falls, or postural hypertension. Long-acting calcium channel blockers and thiazide-like diuretics are often useful, particularly for isolated systolic hypertension. In coronary disease or angina, beta blockers and calcium channel blockers can help symptoms, while ACE inhibitors or ARBs are added when indicated. After stroke, long-term blood pressure control reduces recurrence, but acute stroke is different and follows separate emergency protocols. The key message is that comorbidity guides drug choice. Hypertension in pregnancy requires special management because both maternal blood pressure and fetal safety must be considered. The main categories are chronic hypertension, gestational hypertension, and preeclampsia. Common oral treatments include labetalol, long-acting nifedipine, and nifedipine, chosen according to contraindications, tolerability, and obstetric guidance. ACE inhibitors, ARDBs, and direct renin inhibitors must be avoided during pregnancy because they can seriously harm the fetus. Diuretics are not routinely used, although loop diuretics may be needed for pulmonary edema. Severe acute hypertension requires urgent treatment in a monitored setting, commonly with labetalol, intravenous hydralazine, or immediate-release nifedipine. Severe headache, visual disturbance, upper abdominal pain, breathlessness, neurological symptoms, or blood pressure of 160/110 or higher should prompt urgent assessment for preeclampsia and related complications. Let us summarize the complete approach to hypertension. First, measure blood pressure correctly using a validated device, appropriate cuff, and proper positioning. Measure both arms initially and repeat elevated readings. Second, confirm persistent hypertension with repeated clinic measurements and, when possible, home or ambulatory monitoring. Third, assess the patient's overall cardiovascular risk and target organ damage, including the heart, brain, kidneys, and retina. Fourth, look for a secondary cause when clinical clues are present, such as kidney disease, primary aldosteronism, sleep apnea, endocrine disorders, coarctation, or blood pressure-raising medicines and substances. Fifth, recommend lifestyle treatment for everyone and add medication according to blood pressure, cardiovascular risk, organ damage, and comorbidities. Common first-line options include an ACE inhibitor or ARB, a calcium channel blocker, and a thiazide-like diuretic. Never combine an ACE inhibitor with an ARB. Sixth, monitor treatment including adherence, side effects, standing blood pressure, kidney function, and electrolytes. Finally, severe hypertension should be assessed for acute organ damage. It is the organ injury, not the number alone, that defines a hypertensive emergency. Hypertension is often silent, but early diagnosis and effective treatment can prevent stroke, heart attack, heart failure, and kidney disease. Thank you for watching. This video is for educational purposes and does not replace current clinical guidelines or individual medical assessment.